Bien, buenas tardes.
Good afternoon. I would like to welcome the chair and vice chair of this foundation scientific committee, Professors Medina and Borja, who are always present at this event. For the eighth year, I welcome you on behalf of the Board of Trustees of the Areces Foundation to this international meeting on ALS in Spain. In fact, the history of the connection between the Ramón Areces Foundation and the Luzón Foundation has been a long history of partnership and friendship and intense cooperation. Our dear Paco Luzón immediately persuaded us to work together, not just because he's always so convincing and charming. It is such a noble cause, this fight against ALS, that we were motivated from day one. And working with Paco Luzón was a true privilege, and he managed to convey to us his dedication and his enthusiasm. I would also like to thank my good friend Joaquín Arran, who's probably also here today with us, for being the contact point between us. The Ramón Areces Foundation is very aware of the importance of everything surrounding the research and treatment of rare diseases, which are one, if not the priority of our scientific committee, and such complex and difficult to treat diseases as ALS, particularly. Lack of knowledge of this disease, I think, is something that should just encourage us to work harder in order to do everything we can to learn more and better treat this disease. It's a huge task. And that's why we should all join in and join forces so we can find a way to combat this disease effectively. The Luzón Foundation, dear Maria Jose, is carrying out extraordinary work in research into this disease. You know, you can count on us, and that the Ramón Areces Foundation will do everything it can to help you. I'd like to congratulate you for a brilliant contribution through your recommendations and initiatives for the drafting of the law to improve the quality of life of people with ALS and other rare diseases in Spain. And in this foundation, we're constantly witnessing the progress and the achievements that are taking place in basic and applied research on difficult-to-treat diseases like ALS. But I know that the Luzón Foundation and the Ramón Areces teams are very dedicated, and we will continue with our efforts to learn more about this disease and to improve the lives of the patients. And we'd also like to greet very warmly. I'd like to thank the Spanish and international speakers who have joined us for this international meeting, which will help us take one more step in this fight. As it says in the introduction to the program, why isn't there a cure for ALS? Why only one treatment has been approved since the 90s? I would like to talk about how therapeutic targets are defined, how pharmaceutical compounds are manufactured, and how trials are analyzed, particularly thinking about why it's so difficult to find a cure and which aspects need to be improved. So I'd like to finish by wishing all of you the greatest possible success in your work today, to everyone's benefit. And thank you very much. And now I have the pleasure of giving the floor to Maria Jose Arregui, who's the executive chair of the foundation. Again, my very best wishes.
Muy buenas tardes a todos.
Good afternoon, everyone. It's a real privilege to be back here again to hold this 8th scientific meeting on ALS. We're all aware of the excellent working relationship that the Foundation has had with the Areces Foundation, as Raimundo has pointed out, because of the relationship between our patron, Joaquín de la Rama, and Raimundo's constant support for our cause. I would like to thank the President and Vice President of the Scientific Committee of the Areces Foundation for being here today. You've always trusted us, and we, year after year, thank you for that from the heart. Our founder, Francisco Luzón, participated on July 13th, 2017, in the first ALS meeting that took place here in this auditorium, which brings me to my next comment. Paco Luzón, from those beginnings, was absolutely convinced that research was one of the pillars that our foundation should focus on. And this 8th meeting, I think, demonstrates how right that decision was and how inspired our founder was when he looked at ALS in Spain back in 2017 and saw what needed to be done. And today, we feel stronger because we know that we've worked together with the ALS community in order to get the law passed, a great achievement for which all of us are to be congratulated. And our ability to influence the world of scientific research is unquestionable, both at the national and international level. And that's why today we have amongst us top international and national researchers whom we'd like to thank for being here today and for the commitment that they have demonstrated towards fight against ALS. We've known Orla and Ruben for years. They attended the global ALS meeting in Canada, have ended that meeting, traveled back to their countries, packed their bags again, and traveled here to be with us, and we'd like to thank them for making that effort. To have all this talent here today, talking about state-of-the-art ALS is key so that we can share the results of research and disseminate knowledge, help problem solving, and establish synergies for cooperation. Because with more cooperation, we will need less time to make new discoveries, increase the impact of the results, make them more visible, and awaken the interest of the scientific community towards this disease. And going back to the topic of this meeting, why we don't have a cure for ALS, why there's only one approved treatment by the European drug agencies since the 90s, as Raimundo has pointed out. And today I would like to talk about how therapeutic targets are defined, how pharmaceutical compounds are manufactured, and how trials are carried out, especially from the point of view of considering why it's so difficult to find a cure and which aspects need to be improved so that we can find a cure sooner. I'm sure that this is going to be an extremely interesting event, which will fill us all with hope and energy so we can keep working to find a treatment for ALS. Thank you very much.
Ahora queremos que veáis
And now we'd like to show you a short video about the foundation, and then I will introduce our first moderator and speaker.
Preciso momento, cada segundo cuenta. Imagina que solo tuvieras un minuto para cambiar el destino de miles de personas. La Fundación Luzón vive cada día con esta cuenta atrás. Una carrera contra el tiempo por un futuro sin ELA. Pero ¿quién es la Fundación Luzón? Somos más que una organización. Queremos ser un rayo de esperanza para aquellos que enfrentan la ELA. El primer paso es conocer y comprender el terreno al que nos enfrentamos para descubrir sus dietas, curvas y desniveles. Por eso, 8 de cada 10 euros de nuestro presupuesto lo destinamos a investigación, tanto básica como clínica. La búsqueda de un tratamiento es nuestra meta. Te podrás caer, pero levántate con más impulso. En esta carrera no estamos solos. Contamos con las voces de la comunidad de la ELA. Trabajamos para mejorar la calidad de vida de los enfermos y sus familias. Fortalecemos el tejido asociativo en torno a la ELA para que nuestras pisadas suenen más fuerte. Que nos escuchen los que toman las decisiones, aportando nuestro conocimiento y experiencia para proteger los derechos de los enfermos de ELA. Para que la ley nos conceda un respiro y no haga tan dura la carrera. Para que no se olviden de nosotros, de nuestra lucha. Porque es una enfermedad rara, pero no permitiremos que sea invisible. Esta cuenta atrás ha terminado, pero muchas otras han comenzado. Para que no nos quedemos sin tiempo. Por un futuro sin ELA. Conócenos en ffluzon.org. Fundación Luzón. Unidos contra la ELA.
Voy a pasar a presentar.
I will now introduce Dr. Vázquez Costa, who's got a degree in neurology and a PhD in neuromuscular disease from 2019. Since 2013, he's been caring for patients suffering from motor neuron disease, and he got a Juan Rodés Grant for Excellence of the Carlos III Institute in 2013 to coordinate the unit for motor neuron disease at the La Fe Hospital. He co-chairs the ALS Genetics Board, and he is a member of the Spanish Network of Research into Rare Diseases. He's taken part in over 20 research projects and over 30 clinical trials for ALS and ME, and he's published over 80 articles in peer-reviewed publications. He's also had fellowships in the Department of Psychiatry of Limicum University in Freiburg, Germany, and in the Martinez Center for Biomedical Imaging in Boston. And he's partnered and continues to partner with researchers from multiple research institutes and universities. Since November 2019, he's been Associate Professor of Neurology at the University of Valencia, has received 3 awards for his work on AM, Best Partnership Between Researchers and Patients, and the Best Researcher Award. He's a member of our scientific committee, and he chairs the scientific committee of the National ALS Registry, which is a project which is currently underway and in which we have great hopes and expectations. Thank you very much for everything and for being here. Okay, good afternoon, everyone, and thank you to the Luzón Foundation and the Ramón Areces Foundation for hosting this event, which I hope will be of interest to all of you. I know that it will be, because we're talking about topics that are extremely important for patients, which are treatments. But first, we're going to start with a session in which 2 colleagues and friends are going to give us an overview of what was presented in the latest Global ALS Congress in Montreal, in Canada. I'm going to introduce them, so I'm going to switch to English now. And so those of you who need interpreting should get your headphones on so you can follow this. We're going to start with Dr. Alberto García Redondo,
investigator of the ALS Research Laboratory at the Health Research Institute of Hospital 12 de Octubre. And he and his work team, they work together with the ALS unit of the hospital, and they are responsible for the treatment of ALS patients in this hospital. Their line of work is, and they are a national and international reference center in the molecular diagnosis of ALS, in frontotemporal dementia and other neuromuscular diseases. Alberto is also associate professor in the Department of Biochemistry and Molecular Biology in the section of the Faculty of Pharmacy at the Universidad Complutense in Madrid. And the next speaker will be Mónica Povedano. She is also a very good friend of mine and a wonderful researcher and clinician. Mónica is a neurophysiologist, and she's the coordinator of the functional unit of motor neurons in the Hospital of Belviche. Hospital of Belviche is a reference center for motor neuron pathologies in Spain. And Mónica also teaches in the postgraduate program in EMG and neuromuscular disorders at the University of Barcelona. She's very involved in the ALS registry of her hospital and in the promotion of the national registry and international registry. She's involved in the TRICALS and the precision projects. And Mónica has a huge international projection. She's the leader in the international field from Spain, and she has participated in a lot of national and international clinical trials and research projects. So both Alberto and Mónica, they are part of the scientific committee of the Francisco Luzón Foundation and of the National ALS Registry in Spain. So, Alberto, thank you for being here.
Okay. Hola, buenas tardes a todos. ¿Qué tal?
Good afternoon, everyone. How are you? First of all, I want to thank the organizers for giving me the chance to tell you, I'll give you a short summary of the papers that had more to do with basic research on ALS in the International Symposium. This information is probably not quite as relevant for patients, not like clinical trials, but they are still extremely important in order to further knowledge. And so I'm going to try and share with you the most important conclusions that I've been able to draw from this international symposium. The Congress started on Friday, last Friday, the 6th. And usually the organizers decide to open with a keynote lecture where they describe the most relevant characteristics of ALS research. And this year they decided to have Dr. Caulfield, who is a law professor from Alberta University in Canada, and who's also a government advisor, scientific advisor on health. And his talk was about the difference between myth and reality in biomedical research, and how currently misinformation and fake news are spreading lies online constantly. This is an article published in Science which shows that this happens very commonly in science. And so he talked about that and how memes are how knowledge is being shared in general. And these memes may be connected with reality or not. And in this other study which he showed, you can see how negative and emotionally manipulative news, fear, disgust are on the rise in the web in the last years, and how joy is generally decreasing in all the news that are being spread and generated. And he's come up with a new concept which he calls science-ploitation, and it's how scientific knowledge is being exploited, how they use scientific concepts. Big companies are using scientific companies to try and exploiters all in general, and he used several examples of ALS patients, for example, about the use of stem cells or other therapies which actually have no effect, but which are nevertheless being offered. And in fact, there's quite a lot of traveling for that purpose, like in Cancun, in Mexico. So that was the general introduction to the symposium. And then it's split into three lines, and you have to choose one. First, you have to choose between genetics, improving clinical management, or pre-symptomatic detection and early diagnosis. And in each of them, they talk about the latest findings in each of these fields. And as you will see, particularly for those of you who are not used to going to these conferences, it's really difficult to hear everything and to attend all the sessions because there's all kinds of things going on at the same time. And I chose the genetics part. Genetics is very important and needs to be studied in these types of diseases because they're the only type of study that can give us some certainty about the causes of the disease. And over the years, we've learned of about up to 50 genes connected with this disease. And the first talk was by a doctor from Kenya and a neurologist from South Africa, and they spoke about these differences and similarities in ALS in the African population versus the rest of the world. And from a clinical point of view, it also seemed that one of the characteristics is that the age of onset is younger in Africans and in Afro-descendants versus Caucasians, particularly in the studies with more or larger number of patients in South Africa. There's also some characteristics that are different in the African population than in other population groups with this disease elsewhere in the world. And so with that, we can classify globally, and this is going to happen more and more because up to now we had the European and the American population and partly also some Asian population, particularly in Japan. But we can see how the same genetic variations can be found in different parts of the world. Other genetic research, which is also very relevant, was presented by a Dutch group from the University of Utrecht and an Australian group from Sydney, and how using bioinformatics in these types of sporadic ALS patients, which we thought had no genetic characteristics, can actually be clustered also once you know more about the sequencing of their genome and how you can group them into some main macro families. We think relatives with the disease, but in these research teams, they're trying to create these macro families which can connect different variants. And there's an example that has been recently published here in Spain of some people who suffered ALS in the area of La Rioja, and a team from Barcelona from the Sao Paulo hospital has found a common mutation in all of these people, all of which were thought to suffer from sporadic ALS. Other very interesting genetic characteristics, I found this very striking, this study, which was presented by Pearson from Canada, and how alterations that appear in the more common genetic characteristic, which is that chromosome 9 expansion, and how this expansion might be connected with chromosome alterations. That is, the chromosome itself is actually altered, breaks, as you can see in the image, or they may even be some recombinant effects from one generation to the next, which are also very relevant. And this might, we don't know yet, but it might be connected, and it's definitely a very new finding, with some cases mutations in this gene, patients with ALS symptomatology and others with frontal temporal dementia. And there were various sessions. I chose the one on glia. And glia are all the cells that are not neurons, which are in the nervous system and which help it to survive. And it's the immune system of the central nervous system. And how studying the glia can help us understand and discover new therapeutic targets, specific neurodegeneration mechanisms of some specific mutations can be connected to the glia itself, and also some animal model tests using antibodies against inflammatory proteins, which have been quite successful in animal models. In the following session, it was either in vitro models, epidemiology, or heterogeneity in M&D. I selected the in vitro models sessions, and there they spoke about how the use of pluripotential cells, which is obtaining cells from the skin or blood cells of the patient, white blood cells, you can revert them back to a pluripotential state and generate any kind of cell lineage, and how using cells of this type in patients, you can use them as a model to induce the disease. And they presented a study where on a dish in the lab, they could grow neurons and muscular cells and create the neuromuscular plate to see how there might be alterations in the structures in patients. The following day, on the Saturday, it was either cellular biology and pathology or respiratory management or neuroimaging. As you can see, there's multiple different sessions you can attend. And in cellular cell biology, I chose this one, which is about chaperone cells in the aggregation of TDP43. TDP43 is the protein that most commonly aggregates in neurons in patients with motor neuron diseases, and it aggregates because there's an alteration in the 3D structure of this protein. For the proteins in our cells to operate properly, other proteins are needed to shield them and modulate them, which are called these chaperone cells and these chaperone proteins. And this team from Australia has studied the chaperone proteins around TDP43, which are altered and which might be relevant to prevent the aggregation of this protein, since it's a common aggregate in all types of patients. Using this as a therapeutic target in the future could be quite relevant. And this is the example, and you can see how by using this chaperone proteins, there's a reduction in the aggregation of TDP43.
También.
And also there was a study presented where we see the transmission between cells of badly folded cells of these proteins. You see on the image how it starts with a focal beginning, improperly folded proteins in that area of the central nervous system, and then they move into adjacent areas, and that can be the cause of the spread of the disease. We've seen in different kinds of improperly folded proteins and supraoxidized mutase, which is one of the most important features of ALS. In terms of proteins and proteotoxicity, this UK group presented said how the type of folds of the proteins can add ideas about different therapeutic targets. So TDP43, which is the protein that accumulates most in the frontotemporal area, is accumulated differently, and you see in type C, it accumulates with another additional protein called ANXA11, and through interaction between these proteins, the new therapeutic targets could be found. Another group from the UK gave a presentation on TDP43 pathology. This is a Scottish group, and we see directly this in other tissues apart from the central nervous system. When you do a biopsy on an ALS patient, it's impossible to do a biopsy of the central nervous system because you will interfere with their cognition on mobility. This group studied other areas, tissues, and looked at their liver, the gut, or the digestive system, and they're looking at TDP43 with interesting results. And also, they've done this study and other studies like Parkinson's and Alzheimer's. Let's go to the last day, Sunday. There were mice models of the disease, multidisciplinary follow-up from the policy and practical point of view, and biomarkers. Biomarkers are very important in this disease because with them we can diagnose it better, we can do better follow-up, we can manage the patients better, we can predict through clinical trials what the effect of the drug that we're using is going to be, or find predictive markers that will tell us if we're going to be able to develop the disease in the future or not, or prognostic markers that allow us to understand what the course of the disease will be in each person differently, and we can stratify patients in different groups. Alberto Catanese from Germany, Ulm University, presented a study where using the data from the Tofersen clinical trial in patients with superoxidase mutations, they found markers that could be interesting. And he presented how prognostic markers, not diagnostic, but prognostic markers, the A-beta amyloid, which could be interesting to follow up the disease when A-beta amyloid is a protein that accumulates in Alzheimer patients. That's nothing to do with ALS, but it's a very interesting idea. He also presented, as you see in the picture, that there were differences between males and females. This is a very summarized report on the conference, and next year we hope to continue to talk about important issues at the San Diego conference in California. Thank you.
¿Qué tal?
Good. How's it going? Let me try to keep to the 10 minutes that we have to present this. I want to thank the Luzón Foundation and the Ramón Areces Foundation for giving us the opportunity to be here. We're very cold. It was very, very cold in Montreal, but it was worthwhile. This was the situation in the street, this picture. I fell over, actually, and people working with me also slipped and fell. But we had to go, so we went.
As you can see, than in Montreal. So, bueno, yo voy a ir.
I'm going to... We arrived a few days earlier because there were preliminary meetings that we were interested in, and in those meetings, one of them was a full day focused on the Precision ALS project. We're part at the Belviche Hospital, a part of it, and La Fe Hospital in Valencia is part of it, and it's a project which the Luzón Foundation has supported by investing financially in the development of the project, because we believe that the platforms will be the future. These are platforms to collect clinical data that will allow us to do good epidemiology and collect biochemical data, biomarkers, neuroimaging evidence. And this is the European platform, which within the general, more general platform is going to be used, and we discussed it for a full day. That same day, we had a meeting on a disease that is, we're trying to see whether, look into it, which is primary lateral sclerosis, PLS, and patients that are here or following us online will be familiar with this PLS diagnosis. Is it a different disease, or is it a subcategory of ALS? There's a group led by Dr. Mitsumoto, who's going to retire soon, that are working on looking for biomarkers to describe PLS better. And then I had the opportunity to take part in the symposium on motor neuron disease, which within the World Federation of Neurology was held the day before, the 6th, where we met to talk about respiratory management quality standards when it comes to treating patients, and how this respiratory management is done and how it can have an impact on outcomes in clinical trials, the importance of early ventilation, And different opinions and experiences were presented. I explained about our experience at the hospital, the VIII hospital. Then there was the Japanese experience, Swedish, US, and Rouen chaired the meeting and then led the debate. And I think it's very important to look at how we manage patients from the respiratory point of view, the impact on their survival and the impact it might have on clinical trials. Having said that, I want to repeat, because this meeting is for professionals, but also for patients and patients that are following us online. I found it very interesting. I found the opening lecture very interesting that Alberto mentioned, and how careful we must be about where we get our news and how we interpret it, what our sources are, where it comes from, because there are fake news. There's a lot of fake news around in science too, and this can have a significant impact and generate hopes and expectations in patients that are false. And it was an opening lecture that was very good and very interesting. If we go to the lectures, more specific lectures, Alberto is more well organized than I am. He's given you the dates, the talks. I'm going to go to the general messages that I came home with. From the point of view of a clinical point of view, the talks were associated with multidisciplinary management of the disease in multidisciplinary departments, and I was struck by the presentation on the lack of use of neurodexter in the departments. We could study in Spain to what extent we're using this, and Raul, who works with me, is smiling because within our department we don't really manage things consistently, and things could improve. This could improve the patient's situation very much. And also there was a presentation on epidemiological studies and platforms to tell us that the disease is not static. It is the course of the disease is very different in different patients, and there are different factors, risk factors, and this is associated with the importance. And this was also, there were lectures on this, the importance of asymptomatic carriers of mutations, SOD1 mutations or C9 mutations, and the study of these carriers. If we have a patient that has a mutation and there's a relative who wants to undergo a test and is a carrier of this mutation and is an ordinary person without the disease, well, the longitudinal study of this through different biomarkers of the potential risk for developing the disease can help us to get to know the pathology better. And this within the framework of precision ALS, we want to work on creating consistent protocols for the studies of asymptomatic carriers. Also, there was a lot of talk about remote monitoring of patients using devices at home and the different techniques that we can implement at the home of the patient to help us to follow the patient remotely, not just within clinical trials, but also within daily clinical practice, and validation of the different scales. As patients know, when they come to the office, we ask them a series of questions that have to do with scales. The ALS functional rating scale, and we spoke about the harmonization of these scales between the US and Europe, and harmonizing what we do in the clinic and what is done at home, because patients can also test themselves at home, and also the use of scales like Rhodes that can help us. Regarding clinical trials, there was a presentation on the platform led by the Oxford group, Dr. Turner, expert ALS platform. They're looking at drugs that have been approved for other uses, and they are looking at they're doing short-term tests in groups of patients to evaluate response to this drug, not at clinical level, but as a biomarker. and compared with the gold standard biomarker to see whether different molecules work or not, and then perhaps they can be studied in clinical trials, because for more than 70 years we've been doing clinical trials that have failed and created expectations in the scientific community and among patients that have not really produced any results. There were many talks on AI too, the use of AI in the different areas that have to do with the disease, and the use of potential digital twins, the creation of a patient using AI, a twin, to reduce the number of patients that are included in the placebo or control group. This is debatable because we have enough patients, maybe not in Europe, but we do in other continents. We've got trials in South America, Southeast Asia. There are patients, there is an adequate number of patients, but we'd have to debate this. Then there were presentations on the DOOR study, which is the clinical trial done in Europe. Let us remember about drugs approved in the US and Canada, phase 2, phase 3 was done in Europe. It's a clinical trial that was promoted by a Spanish company, Laboratorios Ferrer. A trial was done excellently with 300 patients, and it was seen that the outcomes were negative. Also presented was the study by the group of Boston, the Boston group, with an anti-inflammatory together with ciprofloxacin. They saw that there was an impact at the level of miRNAs, and they're going to look at a phase 3 trial. Then there was another clinical trial that was looked at that did not show any outcomes at clinical level. And the Japanese group presented the study with high doses of vitamin B12 that showed benefits on the functional scale and increased survival. This was with the Japanese population, so we should look at this and consider it, and possibly look at a trial with European patients, because as we've seen, ancestry plays maybe a role in the response to treatment. And then there were trials presented using diet, hypercaloric diet protocols to see what their association with the disease was. I also liked and enjoyed the day that we had about ASOs. Today we have 2 drugs approved by the EMA. One was approved many years ago, but recently in 2024, tofersen has been approved, which is associated with patients that have SOD1 mutations. It's a subgroup of patients, but that is a second drug that's been approved by the European Drug Agency. And these ASOs come from the era, from a long time ago, and the trial was done for SOD mutations. The drug was approved, and it works initially by responding to neurofilaments, and then as time prolongs, as the time of the study is prolonged, we see that there is also a clinical response in the long term, and it was approved. And this led to the appearance of potential ASOs that are associated with other genetic alterations. ASOs in patients that have a C9 expansion have not shown no response, or SOD2 mutations. But the Columbia group, together with an American foundation, are developing a project which is ASOs associated with given genetic alterations, the use of ASOs in patients with specific genetic alterations. And now, if there are patients here and they hear us talk about genetic alterations, they might wonder why they're not included in this project. Well, we can't include all the patients in the American project, But if the patient has a genetic alteration and you send the ADN and it's sequenced and their ASO is associated with that gene, they can offer you the oligonucleotide for that patient. But this is a new strategy, a therapeutic strategy for patients with genetic alterations, and that's why the genetic trials and studies in patients are so important. In terms of epidemiology, there were different presentations. There was a look at the alteration of sleep and its association with the development of diseases, and this disease, psychiatric diseases. There was another study on financial and economic deprivation and the progression of the disease, depending on where you live and what your status is. How moderate exercise in asymptomatic carriers of C9, it's been seen that it reduces the risk to develop the disease. We used to say, we know that patients with sporadic disease, intense exercise can be a risk factor. And then there's a paper presented on cell aging and development of motor neuron diseases and its association with exposures. And I think that this is a paper that evidences that we are facing a neurodegenerative disease that has to do with cell age and chronological age that do not necessarily coincide. And that is what is a risk factor. Biomarkers like, as I've said, what I mentioned before, and Alberto has said, neurofilament is the gold standard, but a biomarker is anything that we can measure and can give us information to help us to diagnose the disease, give a prognosis, treat the disease, and therefore we must use biomarkers, neuroimaging biomarkers. There are different groups in Europe and Germany that are studying neuroimages. Biomarkers like the voice, the patient's voice, can help us to see the association between these neuroimaging markers and the results of cognitive assessment. These tests can be done easily. And also there was a new papers on biomarkers that can help us to diagnose patients in the ALS DFT spectrum, biomarkers associated with muscle damage. When we evaluate a patient, we ask for the creatine kinase, which is associated with muscle destruction, and they presented troponins, which are a biomarker that are more associated with muscle regeneration, and these troponins can be tested in a routine blood test, and they correlate with neurofilament very well. Other biomarkers associated with neurodegenerative diseases like the TAU, with some different results, and there was also discussion of microRNAs, and there's a research group working in Spain in this area and its role as a marker in diagnosing the disease. And to finish, well, I've got these take-home messages that I brought back with me. Well, first of all, it's important to standardize management of the disease. There were many discussions on how to standardize management of patients based on multidisciplinary approaches, and the importance of remote monitoring, which I think in Spain is not really well implemented. We've got some models, and we try to work with apps to follow the patients, but I think it's an effort we should make because this is the future of what is being done in the field. And it's very, very important. The platforms are very, very important platforms to collect data. In Europe, we have the TRICALS and its platforms and the data collection process of the Luzón Foundation for the Spanish registry, because we didn't have a Spanish registry of ALS patients. We always talk about theoretical numbers based on incidence and prevalence. We need a registry in Spain that allows us to classify the patients, see what their profile is, and understand better what happens with the disease in Spain. And at this conference, we've seen clearly everybody's talking about registries and platforms. The use of biomarkers, especially neurofilament as a gold standard. Neurofilament, NFL, I was at a meeting yesterday where they were talking about, in terms of daily clinical practice, not all hospitals have access to NFL in our daily clinical practices. Some regions of Spain do, some don't. So to what extent we must do the most to get them in our clinical practice, because they give us a lot of information about the disease. But let's remember imaging biomarkers, neurophysiological biomarkers, the importance of the evoked motor potentials, and other biomarkers that can help us to get to know the disease better. Clinical trials that were presented with negative results, but also in the hope that the new platforms like the one in the UK helps us to find drugs that work and associate biomarkers with response to the drug, and then do a clinical trial so that we don't continue to fail in the clinical trials. And also the importance of genetic studies. The gene is a therapeutic target. We have to sequence patients very well to see whether these new treatments can be any good. And especially also in patients that are carriers of genetic alterations, offer the possibility of testing other relatives to see if there are any asymptomatic carriers in the family, and they can perhaps collaborate in research, because by studying these patients before they develop the disease, we will understand better what actually happens with ALS. And that's all. Thank you.
Bueno, continuamos, vamos.
Let's carry on, continue. We're going to start with the two talks that focus more on drugs and how we can improve the development of drugs and the clinical trials to achieve efficacious treatment and therapies for patients. We have two guests, exceptional guests, international experts in the field, and I'm going to switch to English again to introduce them.
Is Ruben van Eyck. Ruben studied medicine at the University of Utrecht. During his medical studies, he worked as he developed a growing interest in the underlying medical biostatistics and trial methodology. And after he obtained his medical degree, he pursued his interests in clinical trials as a PhD candidate under the supervision of Professor Leonard Vandenberg and Professor Eijkemans. In 2017, he obtained a postgraduate master's science degree in epidemiology at the University of Utrecht, specializing in medical biostatistics. Since 2018, he has been working as a statistical consultant and medical statistician for the Clinical Trial Methodology Group at the Julius Center in Utrecht, in the Netherlands. In 2019, he obtained his PhD thesis and is currently appointed as an assistant professor at the Department of Neurology and Biostatistics in the University Medical Center of Utrecht. His research focuses on addressing methodological challenges in clinical drug development to further accelerate clinical trials for ALS, where he has published very relevant papers in the last few years. In 2020, Ruben was awarded with the Paulo Gontijo Prize to the best ALS researcher under the age of 35. So the stage is yours.
All right, thank you very much. Spanish is not so good, so I will keep it in English if that's okay. So thanks a lot for the introduction and the opportunity to be here today. So I want to talk about the considerations for trial design and think about how can we improve the drug development process. So if we think about trial design, the first thing that we usually do is to think about like the primary outcome. So what is the primary objective that we want to find? So we have in ALS we have basically two options. So the first one is survival. So survival time has long been the gold standard, and showing that a drug improves the survival of a patient leaves very little doubt about its efficacy. The problem with survival is that it requires large and very long clinical trials, and usually on a placebo time. So for that reason, we have also an alternative that's measures of daily function. That's usually a questionnaire, but can also be muscle strength or lung function. The ALSFSR, I think everyone knows that in the room, is the most commonly used. It's very quick. It's an easy solution. So what we see in the recent trials over the last couple of years is that basically all of the trials are using the ALSFSR as primary endpoint. Now, if we look at typical ALSFSR data that we see in trials, it kind of looks like this. So here on the y-axis or the vertical axis, we have the total score of the ALSFSR, and then on the x-axis or the horizontal axis, the time since randomization or time since inclusion of in a trial. And you can see that there are like, let me see if I can. So there are like slow progressing patients, and there are also like faster progressing patients in these data. So if we think about detecting a treatment effect, you can imagine that it's very difficult. And in ALS, we don't expect very large treatment effects. We don't expect that everyone will suddenly stop progressing. So we're usually looking at very small treatment effects. So in this very heterogeneous data set, it becomes very difficult to detect this. And what's a trend in trials is that they're usually not 12 months, but they're much shorter. So for example, here 24 weeks or slightly over 5 months. And what you see happening in the data is that if we look at it now, it looks like all of those patients are slow progressing now all of a sudden. And this is a very common observation. And what we see then often is that the investigators or the trialists are misinterpreting the signs as being a true treatment effect. And this is, then we get these kind of news articles, and this is just from one website, ALS News Today, over the last 2 months, and then we get this over positive findings saying that the drug delayed the disease. But then if we do a longer trial, so for example, again 12 months, and we observe the patients again, and then you can see the typical progression again of the ALS population. And then that results then often in, again, negative findings. So we fail then to replicate these early positive signals if we do a longer trial. So here are two examples from this year. So the Amylyx drug and edaravone, both didn't make it in the phase 3 studies. So a very common challenge in ALS development process. So how we go from an early stage drug. We have a positive signal, and how are we going to translate that now to a large phase 3 trial? Those are very costly, and they cost also a lot of time. And because we don't make a good decision, this has become a very big challenge in ALS research. One of the risk studies for these early phase trials are the small sample sizes and the short duration. So you can imagine that if you have a very small study, the risk of capturing just a few slow progressing patients is very high, and then you can easily misinterpret the signals. So how should we then prove like if a drug is efficacious? So the best way would be if we have something like a time machine. So we can treat the patient today, we can follow the patient up for 12 months, note their ALSFSR score or the muscle strength, and then go back in time and then don't treat the patient and then see what happens. That's the only way how we can truly prove whether a drug was efficacious. So we're working on this in Utrecht. We're not successful yet, but in the meantime, we're looking at other solutions. And the gold standard to prove that something works is the randomized controlled clinical trial. So basically what we're doing is that we start over here. So we have a group of patients, and that group of patients consists out of slow and fast progressing patients. And those, by means of the randomization or like a lottery, are then divided into groups. So here a group there and a group up there. And how you can see this is that by doing this randomization, so basically what you're creating is two parallel worlds. So we make one copy, so I take like one sample out of this room, and then that I give the drug A, and then I take another sample out of this room and that take the drug B. And what you're basically doing is creating two parallel worlds, and everything is the same in those worlds except for the treatment that I give them. So this is what happens in a randomized trial, and then I follow those patients up for a certain number of time, and then at the end of the follow-up period, I do a comparison, and then I can show that maybe the patients who are treated with drug A are different from the patients who are treated with drug B. So here's an example. So here on the left-hand side is the data that I showed you earlier. On the right-hand side, I've now also added another group. So this is group B. And you can see that now in both groups, basically there are the slow progressing patients and there are the fast progressing patients. But when we look at the average, you can see that these trend lines are very similar. So what you can learn from a randomized trial is that they're on the average group pattern. So why does the average differ between A and B? And this is a very common misconception, is that people also think that you can use a randomized trial or any trial in general to say something about the individual patient. So if we take this slow progressor over here, then you cannot say that the patient is a slow progressor because of the drug or like because he's in group A. It can also just because of the disease. So a trial in general can only say something about the average treatment effect. So I always get very suspicious if I read about response rates in trials, because that's something we can simply not determine unless you have a time machine. So in principle, this is a very good way of showing like the average drug effect of a new drug. The problem is that you need a group of patients to say something about that average effect between the two groups. You need some follow-up time, so it becomes a very expensive study. You need a lot of patients. And what's maybe the main problem is that drug B is usually not the drug, but it is a placebo. So we put patients on placebo and then we follow them up. So that's why it's so important to think about trial design. So how can we optimize this process? Because this is the only tool that we have to show that the drug actually works. So there I want to go over a little bit about the options that we have. So the first thing that we can do is to think about like the in and exclusion criteria. So we can think about if we don't include slow progressing patients or we don't include very fast progressing patients, you reduce that variability that I showed you in the data. And by doing that, it makes it much easier to detect this average trend and to say whether drug A or drug B has a differential effect. So one of the strategies to do that is by using prediction models, and this is a very important field, I think, because you can use prediction model to predict who's going to be a slow progressing patient, who's going to be a fast progressing patient, and then based on that prediction, we can select those or exclude those patients from trial populations, and by doing that, we can actually detect the drug effect much easier. The same goes for can we predict disease severity, so early or late stage disease patients. So there's a common consensus that the earlier start with ALS treatment, the bigger the drug effect. So by predicting who is in the early disease stages, we can also better select the most responding populations and hopefully create the biggest contrast between two randomized arms. So an example of that is the ENCOS survival prediction model. So this model has been developed in over 10,000 patients, and there are several publications on it, how we show that by using a risk-based selection of patients, you're actually always more efficient than using any combination of conventional criteria. So we can select patients based on their symptom duration or the vital capacity or age, but those methods of patient selection are always inferior compared to the prediction model. So we've been using that in several trials also at the moment. So we made a calculator also that to facilitate the process, and it's a very active research field. So this is just a PubMed search, and you can see that like the interest in prediction models is growing. And Monica already briefly mentioned it about digital twins. I think that's a very important topic because you can use those digital twins. Those are actually predictions of a patient. So maybe based on those predictions, we can even further refine the selection process for trials. So another way to think about how to improve trial design is to actually think about, can we do something with the placebo arm? So can we reduce the placebo arm, or can we add more data to the placebo arm? So that's about like external data or real-world data or real-world evidence, also known. So here's just one example of how you could think about that in theory. I need to look there. So you have a group of eligible patients, then we randomize those patients to active and placebo. So that's basically the same scheme as I showed before. But now we have this third group. And from all the patients that are eligible for a drug trial, and that has been shown in several papers, we know that actually the majority of patients somehow do not participate in trials. So in the Netherlands, it's about 80%. So 80% of the patients who could participate in trials are somehow not participating. So there's a very large group. But that group of patients we can follow up in registries, and so in electronic healthcare records or claims or registries, and precision ALS was already briefly mentioned. So what we can do now is to actually compare these non-participating patients, and we can collect their survival data or their ALS-FSR data, and we can compare that to the actual randomized patients. So if those two groups are kind of similar, then we have, I would have a lot of trust to actually borrow that registry data then into my trial and to make a more informed decision about the treatment effect. So we have here an example of that. So this is a publication that we published last year. So on the y-axis is the survival time, on the x-axis is the time since randomization in this actual trial. So in red is the survival of the randomized control. So these were the patients participating in the trial randomized to placebo. And then we used the external data set, so a registry, what's based also on precision ALS. And we used them to find external patients who are eligible for the trial but somehow not participating. And with a little bit of statistics, you can actually show that these two groups are very similar. And we use those, we then combine those two groups together, and then we compared it to the active drug arm. And there on the right, you can see then what that does for the study. So we can actually prevent randomizing patients to placebo. But you can also, if a patient is randomized to placebo, reduce the time that he is on placebo. And by doing that, you can actually optimize the drug process. Now, the last example is that we can also think about how can we make the follow-up duration more efficient. And one of the ways is to invest in new outcomes and new biomarkers that were already briefly mentioned. So here I have just an example. So digital healthcare technology, also mentioned by Monica, is a very important and upcoming field. There are different ways of how can we implement it. We can think about apps, or you can think about audio assessments, speech assessments, or asking the patient to remotely monitor their vital capacity. Or I like the actigraph a lot, so tracking the actual activity of a patient at home. And the benefit of these markers is that they become very objective, and they're very objective quantification of function and progression, much more than a questionnaire. And because they're so objective, we can often also reduce the sample size that's required for a trial. And by reducing the sample size, you can also think about lowering the number of patients on placebo or shortening the trial duration. Another benefit, and this was shown in a recent paper, is that these outcomes can also be predictive, very predictive of long-term outcomes. For example, mortality. So by including these outcomes, we can also say something about and extrapolate to bigger outcomes, and again think about reducing the follow-up duration in that sense. Also for patients, it might be easier then to participate. So if we think about ways to try to reach that 80% that doesn't participate in the trial, probably it's because of the burden for those patients. So thinking about ways, how can we facilitate that, maybe by home monitoring or decentralized monitoring, we can improve participation rates as well. So in summary, this is a very important framework, I think, this randomized control design. It's the gold standard, and it's what we need to determine whether a drug is beneficial, but we can do a lot of improvements on it, and there's a lot of active research as well. So I've just highlighted 3 areas, but there's also much more different ways that we can further optimize it. So from a statistical perspective, we can also think about how can we optimize the randomization process? Can we maybe leverage some information that we have on like the genetics, so those are adaptive designs or enrichment designs. We can think about like the follow-up, so information-based monitoring is upcoming, so that you only continue follow-up until you reach enough information, and if you have collected the information, you stop the trial. To avoid unnecessary time on placebo. And also of the data that we've collected, so how can we make optimal decisions on that, and how can we optimally use all of these outcomes? So we have survival, we have ALS-FSR, vital capacity. How can we combine that to make like an informed decision? So innovative statistical models are also an important area, I think, to improve. So with this, I would like to finish and thank everyone who's involved in the TRICALS network and in ongoing research, and thank you for your attention.
So thank you, Ruben, for your wonderful presentation. We are going to do some changes in the program because we are a little bit late. So we are going to skip the break. And just right after Dr. Hardiman, Professor Hardiman's talk, we will have just 5 minutes just to get ready the stage, and we will continue afterwards with the debate and the questions. So our next speaker is Professor Orla Hardiman. She's a world leader in ALS. She got her bachelor in science. This is going to take some time. You have a very long curriculum. And I'm studying in the university, so he studied in the University College of Dublin, and she undertook a residency and fellowship at the Harvard program in Boston. She was appointed as a consultant neurologist in the Beaumont Hospital in 1996, and she joined the academic faculty of Trinity College in Dublin in 2013 as the first full professor of neurology in Ireland in modern times. She's the founder of the academic unit of neurology at the Trinity College in Dublin. Her research group comprises over 50 individuals working in neurodegeneration with a particular focus on ALS and frontotemporal dementia. She's author of over 500 peer-reviewed publications with over 35,000 citations and a very high age index. She's a principal investigator in the in Future Neuro and ADAPT centers, and leads the Precision ALS project and consortium. Professor Hardiman is also co-chair of the European Network to Cure ALS, ENCALS, and the European Treatment Initiative to Cure ALS, TRICALS. And she is the editor-in-chief of the journal Amyotrophic Lateral Sclerosis and the Frontotemporal Degeneration, which is the reference journal for ALS internationally. She also leads a clinical trial group for ALS and has participated in more than 30 clinical trials as a principal investigator. Professor Hardiman is recipient of a number of international awards, including the AAN Sheila Easy Award in 2009, in the International ALS Alliance Forbes Norris Award, the Haley ALS Innovation Award, and in Ireland she received the Tom Connor Distinguished Investigator Award and the Trinity College Provost Innovation Award, as well as the SFI Researcher of the Year Award and the HRB Impact Award. I think that's all. So thank you for being here, and the stage is yours.
Gracias mucho. Lo siento, tengo que hablar en inglés, en hiberno inglés. So thank you very much for the introduction and for the invitation to speak today. So I'm going to talk about where we are at as from a clinical point of view in terms of clinical trials. So there are my disclosures. And just a couple of sort of introductory settings. So ALS is not just a disorder of the motor system. There are other parts of the nervous system that are also involved, and we need to remember that because we don't think about that enough when we're doing clinical trials. We also know that ALS, about 50% of people with ALS have a genetic component, so it accounts for about 50% of the risk. So we're born with our genetics, and then things happen to us during our life which contribute to the risk. And then at some point the disease develops. And then when the disease develops, it may be the point where it's very difficult to treat, and we should remember that. We know that there are many genes associated with ALS, and as I mentioned earlier, at least 40 genes. The new technologies, informatics, have helped us to identify genes. This is an old slide, so many genes, but really only 4 that are important in Europe. This is the SOD1, C9orf72, TB42 and FUS, but also there have been trials in some of the other genes, particularly in ataxin. We know a little bit more about some of the genes that might contribute to the disease, not causative, and we did this by something called genome-wide association study, or GWAS, so looking at the variation within our genes in parts of the genes and see if these variations are more common in people who have the disease versus people who don't. So we're part of a large international consortium around the world that is called Project Mine. It's integrated through the University Medical Centre in Utrecht. And so this is the more recent data of almost 30,000 patients. We can see that there are lots of genes that have a little effect in the disease, and so this is going to help us to understand a little bit more. And we know that ALS is linked to other neurodegenerative diseases. Some of these genes are also linked to other degenerative diseases as well, so that's something that we should remember. We also know that ALS is linked to other conditions, and this is work we did a few years ago, looking at the relationship between ALS and neuropsychiatric disorders, particularly schizophrenia. And we were able to find that these diseases have common genetic components to them. So ALS and schizophrenia share about 14% of the genetic, they're overlap by about 14%. That's true also probably for other conditions like autism and bipolar affective disorder. So that's important because it's telling us something important about ALS. These are neurodevelopmental disorders, and we think of ALS as a neurodegenerative disorder. But there is probably something that we need to understand a little bit more about that. We've also been looking at things that occur in family members of people who have ALS. These are called endophenotypes, conditions that may not be associated with the full-blown disease such as ALS, but have some relationship with that. And we see this in some family members of people who have ALS. We see a little bit more neuropsychiatric disorders and cognitive change in some people. And what's really important is that even in family members where the C9orf gene seems to be important, we sometimes see these changes in family members, even if they don't carry the C9orf gene. So that's kind of important. We've also seen a little bit more ALS in family members who carry the C9orf gene. Even people who don't carry the C9orf gene within those families have a slightly higher risk of developing the disease. And that's very important in our understanding of trials, because it's telling us something about what's happening within the nervous system a long time before the disease develops. So this means that our idea of ALS, which really came out of the 1900s or the 1800s in France by this clinician pathologist Charcot, so we sometimes call this Charcot ALS, is based on our very rigid and specific understanding of the disease, which is degeneration of the nerves going from the brain into the spine, and the nerves going from the spine into the muscles that control movement. But it's a lot more complicated than that. And we know that it's heterogeneous. There's more than one type of ALS, and almost certainly more than one cause, many different causes of the condition. So heterogeneity is very important. And thinking and behavioural problems occur in a high proportion of people. Maybe about 30% of people will have a little bit of thinking trouble. There's an overlap with some types of dementia in about 15% of people. And a lot of people with ALS develop other behavioural changes such as apathy. When there is some thinking trouble, that's a negative indicator. So when Ruben is undertaking his cohortization, we need to take account of the presence of cognitive change, particularly our ability to make decisions, because that's an important determinant of progression. And these changes, these different subtypes of the disease, probably tell us a little bit more about the way the disease is occurring, and probably relate not just to the individual cells that are affected, but the way the cells connect to each other, the network. And these features of the disease we don't think about enough, in my opinion, in clinical trials. Also, that what I've shown you also implies that this linkage between ALS and other neurodevelopmental disorders is probably important, because this suggests a shared biology of what's happening, at least in some subgroups of people with ALS. And this suggests maybe these subgroups may share some changes in the way the brain actually develops in the first place. The networking of the brain could relate to the way the cells talk to each other, or the way the cells are developed, and the network is developed very early in life, and the stability of that network. So if we think about this in terms of how we're developing new treatments, the current, what we call the state of the art, is based very much, as Monica said earlier, on our understanding of genetics. So we make assumptions that if we understand what the gene variant is doing, that'll help us to find new treatments. And there have been, these are the various different pathways that you think are involved based on the different genes that we've been able to identify. And there's a lot of experimental work to support this as well, particularly in the animal research that's undertaken. So out of this developed many different drugs over the past 30 years in which I've been involved in ALS, and I've done many clinical trials. Many of these trials were evolved out of successfully treating mice that have the disease. So this is just an example. It's quite an old slide now of many different drugs that came into clinical trial, for which we had really good evidence from animals, from the mouse, that these drugs might have an effect. But unfortunately, when we brought these drugs to the human, they entered what we call the valley of death. So this is the basic scientists here who do really nice experimental work, understanding the biology of what's happening at a single cell level. And this is us over here, where we're trying to capture those drugs. But unfortunately, what happens is these drugs have failed in the what we call the valley of death. So that has to tell us something really important. And some of this has to do with some of the things that Ruben talked about in the way we design our clinical trials. But I would like to take a step back and say there are other reasons why we haven't been successful. Part of this is that we rely too heavily on the animals, and I think we are moving away from that now. ALS is a human disease, it's not an animal disease, so making an animal model of ALS is not a complete model. And the disease is very heterogeneous. We know this, that the factors that induce risk and also the factors that lead to onset and progression are probably different in different patients. And also the way we assess the disease, and Ruben mentioned this, the LS-FRS, is not a very good way of measuring the disease, because it's very variable, as Ruben showed. And if you take out the subgroups of the LS-FRS, it's not linear, and there are a lot of difficulties with this. So these suggest to me that a single target mechanism, or a one-size-fits-all in terms of treatment, is probably a little bit naive, and that we need to rethink how we undertake drug development from that point of view. This is what it feels like to me when I'm doing clinical trials. So this is the disease, and this is what we're doing at the moment. So I think we need to rethink how can we develop trials at an earlier phase, how can we get drugs that are better at stopping the fire from developing in the first place, or putting the fire out with maybe more than one fire extinguisher. If we think about this in terms of how the disease develops, we think about this as the disease being the factors that develop the disease, lead to disease development, are there from birth. So the risk is there, and the risk is developing over time. Monica mentioned the studies that have looked at environmental exposures, the work that's been undertaken in Michigan looking at exposures to toxic pesticides and other toxic elements. So these may be contributing to risk in a population that already has a genetic risk. What is happening then is that throughout our life, we have many different mechanisms. They're called homeostatic mechanisms to attenuate or to deal with toxicity within our nervous system. And these systems work very well in early life and in midlife, and then eventually these compensatory mechanisms fail and the disease develops. And so what we're doing at the moment is we're trying to treat here when the disease is already developed, whereas in fact maybe we should be thinking about looking at these compensatory mechanisms. If we think about this as a model, probably we can think about the disease starting very early on, possibly leading to changes in how our brain networking occurs. Other things happen as we age, and then eventually we develop the disease. But this part here is compensatory, and then this is where the disease develops. So we think about this as a more targeted approach. Could we delay the disease onset or progression? Should we think about symptomatic therapies? Should we think about drugs that modify disease? Well, Monica mentioned the idea that chronological aging and biological aging may be different, and I agree with that. And we've seen this in Ireland, where we have a register for the last 30 years. And we've seen that the age of onset in Ireland has increased over the last 30 years. And that's because our population is aging more slowly. We're healthier as we get older. At least that's our hypothesis. And this also aligns with some work that we mentioned from Michigan, looking at the chronological age and the epigenetic age. And the epigenetic age, these are changes that happen to the genome over time, possibly related to exposures. In ALS, this is a little bit faster. This needs to be replicated, obviously, in other studies. And then these disease-modifying therapies, should we be thinking about targeting compensatory mechanisms or targeting drugs that prevent spread? If we think about targeting therapies, and we think about this in terms of, we think about molecules, this is the cell biology within the nervous system, the cells as they talk to each other, the neuron, the circuit, and the networks. And we have to think about the mechanisms of neurodegeneration in this context. So we think about the risk. So the risk of things like genetic factors, environmental factors. The compensatory mechanisms, and there are many mechanisms that control metabolic stress, immunological mechanisms that maybe can attenuate the development of the disease. And a lot of work developing in that area now around our understanding how the innate immune system works. Inflammatory processes that can both be positive and negative. Thinking about the brain and how the networking of the brain, the established networks, and how they're modulated and how we can compensate those, or different patterns of network change, and the ability of the neuroaxis to modulate its networks, and that aligns back to the idea of a neurodevelopmental process where the integrity of the networks might be impaired a little bit. And then neurovascular coupling. We had a very nice talk at the Montreal talking about the blood-brain barrier and changes in the blood-brain barrier. And then the clinical disease happens when all of these things come together and the system starts failing. So if we want to study compensatory mechanisms, how can we do that if we don't know who's going to get the disease? Well, there are things that we can learn here. We know that there are so-called extreme phenotypes, and Monica mentioned PLS, a very slowly progressive disorder with a normal life expectancy. We could study that. We could study people who have only one arm affected. We could study people who have a gene but don't get the disease. So some people carry the gene throughout life, a 71 or a CNNF72, and never get the disease, so we should be studying these people. We should be studying family members who are members of these families but may not have the gene, but maybe look a little bit different. And And we should think about the idea of biological aging and chronological aging and senescence. So there's some work going on across Europe, in London, for example, in UCL, looking at T-cell senescence and the importance of T-cell senescence and development of disease. So the future of disease-modifying treatments should be tailored to subcohorts, and we should be targeting different pathways and different biological stages. So this probably means that we need drugs with multimodal mechanisms of action, or multiple drugs targeting different pathways. That's the way forward. So the next steps we need to be able to do this at scale. So we need high quality data. We need to be able to bring in as much information as we can about the people who have the condition and people of the rare forms and the family members who carry the gene but don't have the disease. So we can define these subcategories, these people who have family members with neuropsychiatric disease, a very important subgroup, to help to understand the subcategories that will allow us to model out or map out causation, onset, and progression. And then the better understanding the networks that are failing, so that we can develop therapies that are biologically plausible, that target individual subgroups, and these subgroups would have shared pathological or clinical features. So the way we're doing that in Europe is with the Precision ALS program. And this, Monica mentioned this, we have a number of sites, 16 in Europe now, where we're developing a platform where we collect as much information as we can, and then we're applying modern statistical deep learning and artificial intelligence strategies in order for us to be able to subcategorize these people into different groups that are meaningful. And then that will help us to better characterize patients, develop better biological rationale for early phase trials, better trial design, and ultimately better outcome measures. So thank you very much for listening to me.
Thank you, Professor Hardiman, for the wonderful talk. Vamos a montar ahora el escenario. No os marchéis porque...
We're going to set up the stage. Don't leave. In 5 minutes, we'll be back again. So we haven't got time to leave and just stretch your legs and we'll see you in 5 minutes.
Hola. No. Hola. Hello. Hola. ¿Se me oye? Okay. So good. We are starting again, and we have already waiting for us. He's Steve Garofalo. He works in Biogen. Biogen is the company who launched the drug tofersen, the first drug approved for ALS after more than 25 years in Europe. And so Steve Garofalo, he's a PhD in cell and molecular physiology, and he has worked on multiple clinical trials in ALS. He's the medical director of the Neuromuscular Development Unit at Biogen, and he's based in the USA, in Cambridge. So welcome, Steve, and thank you for being here.
Many thanks for the opportunity to open the roundtable and present on learnings from ALS clinical trials run at Biogen. I'm incredibly honored to be part of this meeting today, and I apologize that I could not be there in person. And I really want to extend my thank yous and congratulations to everybody that's been part of this session. It's truly been a very... Okay, so these are my disclosures. All right, so during this presentation, we will review lessons learned from both the successes and failures in running ALS clinical trials at Biogen over the last 15 years or so. And these include learnings from programs such as a small molecule that was developed between 2010 and 2013, as well as multiple antisense oligonucleotides developed over the last 10 years or so. And unfortunately, due to compliance reasons, I'm not able to present specific data from these programs. So we're just going to focus in on the high-level learnings from these trials. And thanks to the collaboration of the ALS community, we have learned so much about running trials in ALS at Biogen, and I've learned a lot from these programs. And some of these themes have already been highlighted during today's session, and probably more eloquently than I will be able to articulate. But some of these themes include, number one, prioritization of targets and therapies that have the strongest scientific rationale, and then utilizing tools to enable early de-risking prior to advancing these molecules to larger registrational studies. Number two, using improved mechanisms to control for disease heterogeneity. And as we've heard and as we know, disease heterogeneity can really vary across and within different subtypes of ALS, so this is especially important. Number three, pursuing novel endpoints and biomarkers from people that have actual experience with the disease. And this is especially important considering the limitations in clinical outcome measures that we know about in ALS. Number four, considering longer studies, open label extension trials, to account for the time needed to observe a drug effect. And then number five, as has been highlighted as well, is accelerating the time to treatment intervention. And on this slide, we'll review some of the key considerations in the selection of drug targets that we've learned from running these ALS programs at Biogen. We know the pathophysiology of ALS is quite complex and is still evolving. And in light of this complexity, determining which pathway or pathways to target has certainly not been clear. And as a result, we've of course observed many drug failures over the years. And these investigational therapies, they really differ with respect to the evidence that has been shown with respect to the target and mechanism of action as tied back to the disease pathology, evidence for preclinical target engagement, and then evidence in a relevant disease animal model. In terms of the target and mechanism of action, we know that there are some therapies that exhibit weak or still evolving evidence, some targets that have initially shown what seems to be a strong connection to the pathology, which have turned out to be more complex. And here I might highlight C9orf72 ALS, where we've seen multiple drugs targeting the sense RNA strand that have led to drug failures in phase 3 trials. So now there's increasing efforts to look at different aspects of the C9 pathology to see whether one of those may be more promising alone or in combination. And then we certainly know about targets that appear to have more strength of connection with respect to the disease pathology. And here I would highlight probably SOD1 ALS and FUS ALS. And then in terms of preclinical target engagement, this also spans the spectrum in terms of available evidence. We've seen investigational therapies have pretty weak evidence all the way to strong evidence. And notably, this can be complicated by some of the limitations with a preclinical target engagement model. One example of this might be an RNA splicing target that may only exhibit aberrant splicing in humans, but not exhibit that phenomenon in animals. So it would be quite difficult to demonstrate target engagement without doing modifications to that animal model. And then in terms of the disease models that are available, again, we've seen quite a lot of variability in terms of existing evidence. Some investigational therapies not showing much evidence, and this may be due to, as has been highlighted, limitations with the animal model itself, the target, or attributes and properties of the drug itself. And then we've observed some investigational therapies that appear to have stronger or even stronger evidence within these animal models. And this may be outcomes like survival, motor function, biomarkers in one or more preclinical efficacy models. And of course, to de-risk drug development, we would want to have all of these parameters have strong evidence. But we know that's likely not possible due to our limited understanding of the disease pathology, as well as limitations in available models to be able to test a drug's effect. And for these reasons, it's also critical to enable tools that can de-risk clinical drug development. And here, one example would be the use of neurofilament data from a phase 1/2 study. And neurofilament is a biomarker of axonal injury and neurodegeneration. And so using this data to essentially serve as go, no-go criteria prior to advancing molecules to larger, longer studies. And notably, the specific tool that's utilized will, of course, depend on the drug's mechanism of action. In addition to selecting the targets that have optimal probability of success, it's also critical to look at other aspects of clinical trial design. And one aspect here that's important to focus on has to do with the mechanisms to control for disease heterogeneity, again, which we know can vary across and within different subtypes of ALS. And here, one example would be in SOD1 associated ALS, where it was initially thought that the specific SOD1 mutation type, as well as pre-study progression on the ALS-FRSR, these were initially thought to be appropriate tools to account for disease heterogeneity in a study population. But we later discovered that there were some notable limitations. As has been pointed out already, the nonlinear decline on ALS-FRSR, as well as differences in disease progression rates across and within different SOD1 mutations really limit the ability of these tools to account for disease heterogeneity. And for these reasons, alternative approaches are being explored, included in clinical trials. One example here would be the use of baseline neurofilament light chain level to serve as a continuous covariate to control for disease heterogeneity within the study population. And notably, this is supported by years of scientific evidence linking neurofilament as a prognostic marker of disease progression and survival rates. In an ideal future state, we would, of course, have even better and more precise tools to account for disease heterogeneity, which may take the form of fluid-based biomarkers, electrophysiological data, or imaging biomarkers, all with the goal of improving clinical trial design. Another key learning, as has been highlighted in this session, has to do with the selection of the primary endpoint, as well as the statistical methodology utilized to evaluate that endpoint. And as was highlighted, we know the ALS-FRSR has been considered the gold standard. We know it's been utilized in many, many clinical trials as part of primary endpoints. We know the scale has its strengths in terms of its ease of administration, correlation with survival, but we know it has very notable limitations. Nonlinear decline, variability across raters. Because it's multidimensional scoring, the same total score may not represent the same level of disease severity across individual participants. Additional limitations include the need for larger studies, longer studies to evaluate for survival outcomes. And then in terms of novel measures, these may be used inconsistently across sites and centers, or they may be being validated against scales that currently have notable limitations. And so where do we go from here? Refinement of existing measures, development of novel measures that can hopefully improve the specificity and sensitivity to detect a drug's true treatment effect. Another key aspect that was also highlighted has to do with study duration. And some key considerations include understanding the relevant disease natural history within the subtype of ALS that's being evaluated. And we know that this, again, can be heterogeneous across and within different subtypes of ALS. Number two, a clear understanding of the timing of a drug's effect with respect to target engagement, downstream biological activity, impact on biomarkers, and then downstream effect on clinical outcomes. And really understanding the timing of all of these effects is critical to understand what is the appropriate study duration to include in a clinical trial. Otherwise, we could risk a false negative result. Another key consideration that was highlighted has to do with the limiting the amount of time on placebo, which is especially important if there is a potentially efficacious therapy that's being evaluated. So here we can consider crossover designs for placebo participants to then go on to active treatment within a trial or open label extension studies. Another way of potentially improving the probability of success has to do with accelerating the time to treatment intervention. And we know by the time ALS clinical symptoms emerge, there is already very substantial motor neuron loss that's been experienced. We also know in other disease areas like spinal muscular atrophy that treating early, pre-symptomatically, is associated with better clinical benefit. So there's really strong rationale to accelerate the time to treatment intervention. And one example of this would be intervening at the time of biological evidence of ALS disease activity prior to symptom onset. And we know, thanks to a lot of work in the scientific literature, there's accumulating evidence for a pre-symptomatic phase of ALS. And one of the most important studies evaluating and supporting this was the pre-symptomatic familial ALS study that followed individuals who were at genetic risk of developing ALS. And so they carried different mutations in genes associated with the disease, including FUS, SOD1, or C9orf72. And within this cohort, neurofilament levels, again, a marker of axonal injury and neurodegeneration, they were followed longitudinally. And what was found is that neurofilament levels were elevated up to 6 months to more than 3 years prior to the onset of clinical symptoms in ALS, which was a huge finding, demonstrating a detectable marker of pre-symptomatic disease that was also monitorable. And so a key question emerges as, can we intervene at the time of evidence of biological disease activity, and will that maximize clinical outcomes for patients and improve the probability of success in our clinical trials? Number two, can we actually design a study like that? And notably, this is being evaluated in the ATLAS trial, which is evaluating the impact of treatment intervention in individuals who are at genetic risk of developing ALS who carry a confirmed mutation in the SOD1 gene. Notably, extending this approach to non-genetic forms of ALS will, of course, require identification of reliable and detectable and monitorable markers of pre-symptomatic disease prior to symptom onset. Finally, I'd just like to thank all the study participants, their caregivers, all of their families, steering committee members, investigators, site staff, and the broader ALS community. None of these trials, these learnings would be possible without these efforts. And it's only through these continuous collaborations that we will continue to advance ALS research with the goal of hopefully meaningfully altering disease trajectories for so many people living with this incredibly devastating and difficult condition. So thank you so much for your time today. Unfortunately, I can't join the Q&A session for today's meeting, but I thank you all for all your time today. Much, much appreciated.
So thank you, Steve, for your wonderful talk. And before starting the roundtable, I'm going to present Miguel Ángel Rubio, who has joined this table. Miguel Ángel Rubio is a neurologist and PhD in neuroscience, and he's coordinator of the Motor Neuron Disease Unit at the Hospital del Mar in Barcelona. Hospital del Mar belongs to the ENCALS network and to the TRICALS platform for both research and clinical trials in ALS. He has participated as a principal investigator in several ALS clinical trials, both industry and academic mediated. And in addition to his clinical practice, he has conducted research in the lab, working with murine models of ALS, and his current research focus is on the development of therapies for genetic forms of ALS through international collaborations. So the other speakers you already know, and I'm going to start making some questions, and the roundtable will be then open to questions of the public. So when I was watching the talk of Steve and other talks, I was thinking, why are we here? We are here because for 30 years there were no successful trials, but we have no new treatment. And what I think, the thing I see, the drugs conundrum is that we have these two kind of molecules, two kind of examples. One is the riluzole-like molecules, which are, we can include there edarabone or AMX0035, where nobody knows exactly how they work. We have very limited preclinical evidence of their efficacy and mechanism of action. We have no target engagement or efficacy biomarkers, but still, in the case of riluzole, still it works. It worked. It was shown in the trials. But for many years, we have done this kind of clinical trials with very little preclinical evidence, without biomarkers showing efficacy, just expecting that it happens again, like it happened with riluzole, that it works, but we don't know how. Yeah, this is the way we did science some years ago. But the other example would be the tofersen example, which is a very well-known mechanism of action with target engagement and efficacy biomarkers. But the problem is that these drugs usually do not reach the phase 3 trials, while the other drugs usually get to the phase 3 trials. Is that right? Do you agree with me? And I would like to ask Ruben, what do you think about this? What is the best approach? We have two examples of drugs for ALS who have been approved with a different background and different methods to come to the approval. What do you think? Because I have the feeling, I have participated myself in many trials with a very little preclinical evidence of efficacy, and even in phase 3 trials where the phase 2 trials were not so impressive, always based on post-hoc analysis, et cetera, et cetera. So can you comment on this?
Yeah, sure. No, I completely agree with you. I think that's exactly the problem in ALS. It's this, so when do you initiate the phase 3, and like what evidence do you need to get there? I think this has been the biggest problem, that we have been initiating phase 3 trials based on evidence that's virtually non-existent. I don't think that's a good strategy. I think that's really something that we need to change. That we only initiate phase 3 trials if we're really confident and about, like, okay, it's going to really do something. So I think where the problem lays is in the early phase trials, because there we don't have good idea of what does a good evidence need to look like. And I think I've been struggling with that myself as well, because we cannot rely on the ALSFRS-R in early phase trial. We cannot rely on survival. So what are we left over with is then, well, maybe like neurofilament, but like riluzole, for example, I don't think we would have found that if we would have relied on neurofilaments, because riluzole probably doesn't show like a very big change in neurofilaments. So I think that's the key piece of the puzzle that we need to think about. So what do we need to have from a phase 2 to make an informed decision? Because I agree, if we keep on relying on like post-hoc findings on the ALS-FSR or like 1,000 statistical tests and then decide to go to phase 3, yeah, the chance that will be successful is very, very small. And yeah, then we end up with a lot of wasted time and funds. So maybe that's the topic of the discussion here. So how do we need to design the phase 2 study? And what does the evidence need to look like?
What do you think, Orla? Do you think we should be stricter with the clinical development or the drugs that reach this clinical development, or should we continue trying to put all the drugs which has been tested in some animal models, put them in clinical trials for the patient? So it's better doing many clinical trials with many drugs simultaneously, or is better to focus in those drugs who really show strong results in the preclinical models? Orla.
I think our model is wrong. I think the model is wrong from the beginning. I mean, it's clearly a complex, heterogeneous disease, and the more I've been thinking about it, the more I think this idea of pre-symptomatic and symptomatic, the neurofilaments go up, the compensatory mechanisms are failing. So I think that relying on a preclinical data set that works and then moving a drug into clinical trial and assuming it's still going to work is probably not correct either if you use all patients. And a very good example of this is the arimoclomol story. So arimoclomol is a drug that upregulates heat shock proteins. It's a very plausible biological mechanism. It works in 2 different models, and Linda Greensmith from London showed this. It worked in an animal model, a VCB model, and also in IPS cells. And when the drug was brought into clinical trial to a phase 3 trial, there was no effect. So there are lots of learnings from that. So we translated from something where there's very good biological plausibility in 2 different models, preclinical models, with a drug that you would think would work, and when it came to the human trials, it didn't. Now, there are lots of reasons why that might have been, but the main reason is that the disease is heterogeneous. It is possible that in some patients where HSP is dysregulated in humans might have benefited, but that biomarker wasn't incorporated into the trial. So we need to take a step back from where we are, assuming that just because we can segregate patients into faster, slower progressors or bulbar or spinal onset, that is adequate. It's not. You know, the mechanisms are different. We know even in monogenic diseases like SOD1, the onset can be different. I was corresponding last night with a lady whose 2 children died of A5V mutation in their 20s, and her husband was a carrier and he doesn't have the disease. So this, even in diseases where there's a single gene and major effect, there's a huge amount of variability, which is probably a combination of genetic and environmental effects. So until we understand the basis of this biological heterogeneity, we are kind of shooting in the dark a little bit. We could develop drugs or drugs that work on the pathways that we think are effective based on our understanding of the biology. So there are drugs in development in that regard. There are a number of drugs that work there's a drug that works on NF2 pathway that works on a different pathway as well. That's about to enter a clinical trial. That makes sense biologically to me. It's working on a number of different pathways, and the output will be the biomarker. The go, no go will be, will that drug change the marker for what NRF2 is doing? So that makes sense to me. And the expectation will be that there will be people who respond and people who don't. And that design will have segregate patients based on that. So that's the way we should be going. And targeting drugs that the idea of a single target that we think is going to fix the disease, that's very naive in my opinion. It might work in mice, but humans are much more complicated. The disease is much more complicated in humans. The A5B mutation, SOD1, does not produce a phenotype in mice, but that's the most aggressive form of SOD1-related disease in humans.
Yeah, I've actually been always surprised that we never translate, that we have no good translation. So from the preclinical model, to the first in human, so we never actually replicate those experiments. So that, like for edaravone or MLX, they have like this preclinical evidence, but they have never tested those biomarkers, I think, like in a smaller study. So I think this is where the key step is, to do that first.
Better target engagement markers for that sort of drugs that you mentioned before, not to take a step further or not in the phase 2 to phase 3 trials. Yeah. I mean, to assess, so to speak, a certain pathway and have in the human a better target engagement marker.
But the idea that we would find a drug that turns the disease off, I mean, this idea of my model of towering inferno, I mean, there are many things happening at the time that the disease becomes apparent to me as a clinician. Much of the mechanisms of compensation within the neuroaxis at a cellular and network level have been overwhelmed. And the idea that we could in some way pull that back in a very effective way seems to me to be asking a little bit too much of a single target.
The idea is to use that sort of target to discard. I mean, we have talked about a certain stubborn phase 3 trial that is going to be repeated. Maybe if we get this sort of markers of efficacy of drug, not in terms of biomarkers of NFL or scales, but of target biomarkers, maybe we can discard for repeating that are errors as well.
Yeah.
And perhaps also improving, the quality of the preclinical studies. I'm thinking about something so simple as having blind studies in mouse, because when you measure survival in mice, well, the mice usually are sacrificed. So if you know which mice are receiving treatment and which no, you can be biased. It's natural. And many studies in mice are done without blinding, which is unbelievable at this time. It should be mandatory, something like this.
Yeah, very good point. I think that there's this older paper, I think it's in the journal from Scott, but they looked at the quality of the preclinical mice models, and it was very, very poor.
Refer to the preclinical. I think that's a 2009 paper. I think.
Yeah,
I think that the quality control is much better now in animal work, but it's still the case that we assume that in a genetically modified animal with a less complicated neuroaxis to what we have, the mouse brain is that size, our brains are this size, that in some way that could immediately translate to this really complicated human disease that is a gene-environment interaction, most likely. To me, it doesn't make any logical sense to me that we make that translation and assume that it's going to work.
So let's talk about one of these riluzole-like drugs, which is methylcobalamin, because we had these 2 trials showing, well, one trial with a post-hoc analysis showing efficacy and one phase 3 trial showing efficacy. This is a drug which is available. What do you think about that? We have a lot of patients interested in.
Yeah, so I find it a confusing study because the original trial was a randomized trial of 16 weeks. The second trial that they just published 2 years ago or last year. And you see the drug effect immediately existing within 4 weeks. And after that, the difference between the two groups remains practically the same. And then at the MNDA last week, they presented new data from their open label extension study, showing that there was a 600-day improvement in survival. I find it very hard to comprehend with the original design because the only difference was a 16-week period, so how can that have been extended to 600 days? So, yeah, I'm not sure. So there was like mentions of like the patients might have been deblinded because of the urine color that's associated with the drug. So it gives it like a reddish color, I think, of the urine, so patients can easily be deblinded and know that they receive active treatment. Yeah, or it might just have been like an artifact of a small study, but I'm a bit worried also because the first trial, which was a very large, well-designed trial of over 2 years, I believe, there was no drug effect in there. So how can it then be that there's such a big drug effect in this smaller study? So I think we're looking at a bit of a distorted result, but that's my opinion. Yeah.
What do you think on that?
I chaired that session. I also saw the original paper before it was published, and I completely agree with Ruben. I think it's really hard to extrapolate from the data that we saw into an assumption of a therapeutic effect. There are also issues around trial design, and this is Ruben's area more than mine, where the study took a long time to recruit, as far as I know, and there were many sites in that study, participating sites, so probably small numbers of patients. So a huge risk of site-to-site variability, and then this question of unblinding as well. So, you know, I don't know that, I found it hard to accept the findings that this was a major therapeutic advance in ALS. I'm not even sure I want to do another trial based on those data. I think Monica does, but
I think it could be interesting still to do another trial, but I'm afraid this is going to be something like the lithium study, similar case. They showed also a huge effect, and then there were 4 trials conducted, all negative. But yeah, I think it's.
But lithium is interesting because lithium, then the post hoc analysis that Michael Van Es did speaks to some of the things I've been saying. So there's a subgroup of people carrying the UNC13A variant who normally would progress very rapidly. And in that subgroup who received lithium, the progression seemed to have slowed down. So we have a study underway now for patients carrying that UNC13A variant to determine whether there is truly an efficacy. So again, that's precision medicine. You know, that's a precision-based approach, selecting out a group that we think might be beneficial based on a post-hoc analysis.
Yeah, so I think there's like a similar consideration for the vitamin B12 because they did this larger study and then they did a subgroup analysis, I think, and now they did specifically a short disease duration patients, I think early in the disease stage, but it's not a biological marker.
This is the same thing that happened in the Darabont.
Yeah.
And so this is the point I've been making, which is that, you know, I've been a clinician for a very long time, and I don't think I'm very good at defining different subgroups of patients. I just don't think we can separate people into subgroups. Is there a question? Okay. You have to translate.
¿Desde cuándo no están traduciendo?
Now it's working?
Okay. Works again? ¿Funciona otra vez? Okay. Okay, so I think it's worth to do a confirmatory trial in Europe. The patients want responses, and we tell them to believe in the scientific community. So part of the scientific community is saying, here we have a new drug, it's working, we have proved it in a trial, well-performed trial. So we need to give them a response, I think. What do you think?
We've done this twice already. It's called Edaravone and Amylyx.
Yeah. So the third.
We need maybe we need another one with vitamin B12.
Okay, let's go back again to the tofersen like drugs, and I would like to ask Miguel Ángel now, because he's working in personalized gene therapy, specifically in ACOs, in oligonucleotides, and there is this project of gene therapy for nano-rare patients, are called. Nano-rare are those patients who have a mutation that are less than 30 people in the world that has the same mutation. So I would like to ask you, Miguel Ángel, how is the process of preparing a drug for a single patient or for 2 patients? How complicated it is, how long it takes to prepare ASO for a specific patient?
Okay, so that process, it is called what is known as an N-of-1 approach. I mean, N-of-1 for one single patient. And it's like developing a drug and performing a clinical trial for one single patient. The part of the beginning with the end the part of the clinical trial is this. It's similar or mostly the same as arranging a clinical trial for a few patients, but obviously single patient, it means that there is no placebo arm. And the story of N-of-1, the developing of that sort of medicines, in fact, Monica mentioned the Spinraza, the nusinersen, and it started with nusinersen somehow. I don't know if you are aware of the story of the first ASO that was developed for a single patient. That was for a child, for a young lady with a very rare disease that is called Batten disease. That is a neuronal lipofuscinosis. And she was diagnosed in Boston, and his pediatrician, it's Tim Yu, that now is very famous. He realized when he read the genetic report for the patient when she was diagnosed, that the mutation was very, very, very similar with the spinal muscle atrophy. And at that moment, there was the Spinraza in the field, and he thought, well, maybe I can make some changes in the Spinraza molecule, and I can give it to that child. And that process, it was very, very, very fast. It was the fastest, and it cannot be achieved nowadays in that, at that time, in 1 year. In 1 year, they developed the ASO. They make the preclinical and efficacy data, the toxicity data, and they put it in the patient in 1 year. This was done in 2018. It was published in the New England Journal of Medicine in 2019. Unfortunately, the children died a few years later, and now the mother is a very famous person in the advocacy of N-of-1 process and trials. In fact, she was awarded in Spain about that 1 year back in Barcelona. And after that, there were emerging groups for rare, ultra-rare, or nano-rare diseases for imitating that process. And there are different platforms around the world, mostly in the US, like N-Lorem, that is involved in the Alliance ALS, N-of-1 collaborative, it's also in the US. In the Netherlands, there is the DCRT, that maybe everyone is aware. In the UK, there is the APNet. This is a pan-European group that is called One Mutation, One Medicine, 1M. And they are working together to develop the guidelines on how all is performed. Overall, nowadays, the whole process, it can take 1.5 years or 2 years to develop and to bring the drug to the human. Usually, there is a first step where there is a selection of the variant, and there is a certain sort of variants that are amenable by ASOs. And when you design the ASO, then you have to prove the efficacy in the cells derived directly from the patient. So usually you take a skin biopsy or PBMCs, you make the reprogrammation, the differentiation into, let's say, motor neurons, and then you prove the ASO. Usually you develop in an academic environment, you develop between 5 to 15 different ASOs, and you prove the efficacy among the different ones, and finally you choose the ones that has the most efficacy. And after that, you have to show that it's safe for the patient. And I didn't mention, but obviously this is done only for very severe diseases with a great disability, with a great rate of lethal. There are diseases that can be lethal. So usually we only need, at least in Europe and in Spain, a safety profile made in the mice only for 1 month. So giving the drug in a mice just for 1 month and know that it's safe, and having all the preclinical data about the efficacy. For instance, if you have to knock down a certain transcript and know that it's doing this, you're ready to go to the patient. So, and the whole process, it's around 1.5 years, 2 years. Less is now, it's very difficult to make it done.
So, do you think in Spain you can implement something like this in the clinical practice? So, imagine you receive in your clinic a patient with a point mutation. What would you tell him?
Wow, that's a very tough question. I mean, again, Monica explained the Silence ALS project, which is a huge project with a high budget, and this is the main hurdle that we have, the budget to make it done, because obviously developing a drug for a patient in the N-of-1 approach is cheaper than developing a drug in a conventional way, but it is still very expensive to do that. So it is hard to being done in an assistential clinical way. I mean, the technology is there, and in fact, we are arranging some personalized ASOs for ataxia telangiectasia in collaboration with AEFAT, which is the Spanish Association of Ataxia telangiectasia, and we are also arranging some personalized ASOs for one single patient, but because we have the budget for one single patient, we cannot do it at that moment for all the patients with the different variants at the moment, but mostly because of the limitation of the budget. Obviously, that is not something that can be done for every patient, and not every patient with single point mutations in ALS, because it has to achieve certain conditions to be amenable, treated by ASO.
Yeah, so what is your estimation? This could perhaps be used in about 5% of patients, or less, 1%?
I would say less than 1%.
Less than 1%. Just to clarify that this is not something that you can apply broadly to ALS patients, only to a minority of them. This accelerated process is more risky for patients because you will have very limited safety data.
That's the reason why this sort of approach it is done only in very disabling, very rare, very lethal conditions. And obviously, you have to tell the patients that the conditions where the drug is developed, and the only data that we know is that safety profile from a mice that was treated only for 28 days.
Okay.
obviously you can have it as a much bigger profile of safety, and if I'm talking now focusing on ALS. Obviously, if you can treat an spastic paraparesis where the time window is not as narrowed as in ALS, maybe you can have the profile for 3 months or so. But what the regulatory agency says for that specific conditions, that diseases that are very lethal and so, with 1 month is enough. If not, we need 3 months.
Okay, so it's something that we could eventually test in a very few group, a very little group of patients, and assuming some risks, and also the risk that it doesn't work at all.
And there is an additional risk, or to say something that if it works, someone has to pay for that drug. So maybe you can have the budget for 1 year treatment, and maybe you can be in that, so to speak, good scenario where, okay, the drug seems to work, and now what? Because we need the money to have the drug manufacturer, and it's not cheap at all.
And that was my next question. Who is going to pay it? Orla, are you paying it?
I think the N of 1 is really innovative. It's happening. Neil Schneider in Colombia, but that's always a question in the back of my mind. You know, we don't have any SOD1 variants in Ireland, so I haven't had to fight for tofersen. But I would have to, if it were, I would have to fight for it. It would be difficult because in the UK. The cost analysis for tofersen looked like it was not going to get supported. I think they found a different way now. But it's a real big problem. You know, these drugs that are very costly to make for very small numbers of patients in public health systems like we work, who pays? You know, how many hip surgeries could you get for one ASO? You know, and that's a big problem within a socialized health system.
So I want to open now the debate to the public. If there are any questions for the speakers, for any of them. There's a question there. Pues en español,
Yes, we can translate it, but he needs a microphone. I think he's asking about pseudomine, which is a drug that is being researched by the University of San Diego in a lab headed by Robert Nadiox. And apparently he's using it in SLA, and he's used it in other neurodegenerative diseases. Apparently he's successful. Pseudomine, which is a known drug, and he's not had any problem with doing research in children because it's FDA approved. And so my question is, has anyone tried to use pseudomine in SLA?
Any of us know something about pseudomine for ALS? Pseudomine.
Pseudomine is an old molecule developed 100 years ago to focus for the trypanosomiasis. It's a very large molecule that only can be used by intravenous administration. But Dr. Naviaus, who has a lab in the University of San Diego, has used it in autism spectrum disease, and has been authorized by FDA. So I am sure that this compound will be easy to be approved for us, for ELA.
And you mentioned also there were some experiments done in ALS, or?
Well, I don't know.
You don't know.
Myself, okay. I am a medicinal chemist, and now I am retired, and so I only work in silico. But I work very large studies in silico with pseudomine. It is a multifunctional compound, I test it in a lot of dockings with AI. It is difficult for me. And with all the genes that you have shown in your diapositive, and I found that the affinity for these proteins that are codified by these genes are always very good for suramine.
So I'm not familiar, but that doesn't mean that there aren't data. But a drug like suramine could be, if there's enough data, suitable for the study in the UK.
It is the reason why I worked to design an succedaneous, an homologue of suramine, but small molecule. But I only work in silico, so I cannot use it. I am looking for scientists, for groups that can be synthesize the molecule to ask a small molecule to show if in vivo it works.
So the model, and Ruben is also about this, in the UK, there's a study called Expert ALS. So they take drugs that are repurposed, and so they do an initial assessment of the drug in vitro using iPS cells, and then if it looks like it's safe.
It's in vitro. As far as I know, Dr. Navios has used it directly in children because it is a very old molecule. Yeah. It is safe, and I think it is not needed to make preclinical studies.
So it could be included in the portfolio of drugs that are going to get tested in Expert ALS, where it's an open label study where drugs are safe drugs are administered in an open label manner for 6 months. Yeah. And there are biomarkers, it's neurofilaments, and if the neurofilaments go down, the drug is brought into clinical trial. There's another very old drug called enoxacin, which is an antibiotic, which alters the microRNA pathway. And so that was a very old drug that got repurposed, and there's a phase 2 trial.
There is a lot of drugs now that are being repurposed.
Yes. Yeah.
So the problem is that suramine is very cheap.
Yeah.
And it cannot be patented.
Yeah.
So it is a big problem for the big pharma.
Well, this is also so these sorts of studies are best done as investigator studies. So Expert ALS is investigator-led, and enoxacin was also, it's undertaken in Canada, is an investigator-led study. So you're right that these off-patent drugs, which might be very beneficial, need a different pathway for development or for assessment. And I think you may want to comment, but Expert is a very good way of doing that.
Yeah, so Expert is especially developed for these kind of drugs because industry doesn't have interest in this drug because there's no money to be made. Yeah.
This is the reason why I try to develop a small molecule, but mimicking the suramine. It is possible, at least in silico.
Yeah.
Yes.
We can tell the people in Expert to contact you.
Right.
Sí, sí.
Sí, sí.
One question.
Well, given that the pharmaceutical industry is looking to extend clinical trials to, or take clinical trials to other countries, and knowing that the underlying genetics and exposure to environmental agents also plays a role in the disease, do you think it might be a problem to carry out clinical trials in such diverse genetic populations, and that we should go towards more targeted digital twin type studies to homogenize the populations under study, or not?
It is indeed much more complex. So if we're going to go for super rare variant patients, and maybe like 1% of the patients is eligible, that's going to make very difficult drug development and very expensive. So I'm hopeful that we can go to a model where we can include like all patients in a trial and then adaptively make decisions which drugs fits best. So this is something that they also do in other diseases, so basket trials or umbrella trials. So they have like one disease, but with different kind of subtypes for it, and all of these subtypes are enrolled in the trial. And we try to see which drug or which subtypes responds the best to the drug, and then if a subtype is responding, then you move it forward. So I think we should go to something like this, because doing only trials like tofersen did in only SOD1 or like some other kind of genetic subform, I don't think it's going to be feasible because there's so many different forms. So we need to think about a smarter way in the end.
So I think you're right, Monica. It's very dangerous to say that populations are different genetically, because then you sort of get into kind of eugenics, and But I think that we know that the genomic risk factors are probably important. We know, for example, in Latin America, so we did some work in Cuba, and the risk in the mixed population for developing MS is much lower than the risk in the population that is ancestrally Spanish. So there are modifying factors in populations that are admixed that may change how the disease behaves, and if the proportion of modifying factors differs within a population, that might be problematic. So I think Ruben's idea of umbrella studies where we select drugs and responders, but we don't know enough about the disease to be able to do that yet. I think in cancer we can look at receptors, and we can look at mutational frequencies, and look at the immunology of disease. We're not there yet.
But I think for that reason, I like platforms like Experts. I'm not saying it's the solution, but like having some kind of screening platform where you screen through multiple drugs at the same time, it's helpful. I'm not saying that it should always be selected on neurofilaments, but
I agree. The problem, the small problem with Expert ALS is that the go-no-go is neurofilaments.
Yeah.
And you will recall, Ruben and Monica, at the masterclass last year, when we talked about neurofilaments, the EMA representative was saying, well, we don't know enough about the clearance of neurofilaments. We don't know enough about the biology of neurofilaments. Even knowing in the pre-symptomatic stage, the neurofilaments go, what does that mean? We don't know. We assume it has to do with axonal damage, but we don't really know what's going on with neurofilaments. And Andrea Malaspina has done a lot of work on the biology of neurofilaments and the immune reaction to neurofilaments as well. So the clearance of neurofilaments, we don't know enough about that either to be sure that that's the right outcome, but it is an outcome. Yeah. If they go down, maybe it's good.
Yeah. So another takeaway I had from the MNDA was that there was a lot of talk about the TDP-43, so this as a biomarker.
Yeah.
I think it might be interesting.
It's very involved in advising a company who were using TDP-43 as an outcome, but it's actually quite difficult to measure and quite variable, so it is problematic as well.
But maybe putting like some kind of a biomarker panel in place and see how each drug influences the entire panel. Yeah. Maybe that's where we should go.
Or another biomarker that will develop probably will be cryptic exons. So and it might be possible to see those in these EVs, these vesicles. So there is some data to suggest that perhaps you can measure these. You probably know more about this than I do. Cryptic exons, and that could be a good outcome, but we're not there yet technologically. Is that true?
It seems so. So we know very little about maybe the HDGFEL2. I mean, that's the main cryptic exon peptide that we know at the moment. But I don't think that we are in the position to have it feasible in a clinical trial setting, even, not even in assisted as well.
Yeah. Or maybe in the future.
Are there any questions? Preguntas?
Está viniendo, está viniendo.
Hola, soy Miguel.
Yes, I'm Miguel, and I'm an ALS patient, and I was told I had maybe 5 years to live. And so, of course, if you have to wait for animal models and then phase 1s and this, whatever, isn't there some way to accelerate this? And another question is, now that we have AI and all that, I would like to know whether, with what's available now or perhaps in the future, since AI is evolving so quickly, that might not be useful to accelerate this whole clinical trial process or this drug screening process. Don't you think AI might be able to help speed things up in ALS research too?
When you can answer the AI question, because it's also related with the digital twins, which have been commented, but I think many people don't know exactly what are digital twins and how can they be used in clinical trials to fasten the clinical development.
Yeah. So I definitely agree that AI would be it's going to be very helpful for us. So at one point it might be indeed that it's going to form like this time machine that I showed, so that it's going to so that's the idea of a digital twin, is that you can make such a realistic representation of the patient, that you can entirely predict like what's going to happen to you tomorrow, and not only in like functional terms but also in biological terms. So if you are very well able to predict this, and I think we might be there in maybe a couple of years, because you need a lot of data for this, and this is where AI can help. So to analyze and process that data. Then if we can truly make these digital twins, then we can provide the drug to the patient and assess how the actual pattern deviates from the digital twin pattern. And by using that, we can say something maybe about the drug effectiveness. This is a very, very far future perspective, but yeah, it might be something that we could do in 5 or 10 years already, like initial steps. Yeah.
I think AI is definitely going to help, but we need to remember that the AI and machine learning is only as good as the data that's provided to the computer scientists who do, and the modelers. And if we don't have very good data or incomplete data, the model can be incorrect. So this is why we've designed Precision ALS, because we don't know enough about the disease. We don't have enough input into the models to know that we can accurately predict the type of ALS that you have, the subtype that you have, the biology of what's happening in your body, where I don't think we have enough information. But if we people like you help us to give samples and participate in research, we can put all of that together on our Precision ALS platform, and then with a huge amount of data, we can start undertaking analysis that I wouldn't be able to tell the difference, and neither would Ruben, neither would anybody else here, of the subtype that you have, because it'll be a combination of all of the inputs. So I don't think we're quite there yet in terms of the inputs that we have to be able to be accurate and confident of AI being able to solve these problems yet, but I think we will.
Yeah, no, I agree. And so to come back to your point of how can we accelerate things, because yeah, we're talking about like a timeline in 5 or 10 years, but I think now there's a lot of interest in like these early phase trials and drug screening platforms, and I think this is a very good beginning for now. So things like what we talked about, Experts ALS, but I know there's also a few other initiatives going on, and those are things that might start within a year. And then much more patients get access to drugs, and we can try things, and it's all very data driven, and these data can also feed back in then to initiatives like Precision ALS and base these AI models on. So I think for like the short term, like these drug screening platforms are very promising. Yeah.
I think the field has moved in the way that you would like it to, in that even though our colleague from Biogen was still talking about preclinical models, I think we are moving, and we've debated this at our European meeting, we are moving to, if the drug is safe and there's a good biological mechanism that we think we'll give the drug, we will put the drug into a trial. I think we're moving more towards that now than we were maybe 5 or 10 years ago. Yeah. So we're not it's not an absolute requirement anymore that we use animals if there's a plausible biological reason why the drug might work in humans. There are some drugs where we can bypass the animal work now.
Yeah. Yes. So maybe one point still that I think of what can save time is actually if we have more consensus among us, well, like what does an effective treatment needs to look like? Because we talked about in the beginning about vitamin B12 and about the drug trials, and it is an interesting signal, but we're not convinced about the efficacy. And now, we need to basically do another trial if we really want to be convinced. So if we can better align from the outset, or say, okay, if you show this, then we all believe it as a community that the drug is effective. I think that would be we can save a lot of time by doing that. Yeah.
Pregunto en castellano, bien, sí.
I'll ask in Spanish. The question is, in some studies, we are using neurofilaments to see whether there is a response or not. With tofersen, we saw there was an initial response with a biomarker, but the clinical response did not appear until much later. We had to wait until the open label extension to see that there was an impact on functionality. Based on that, and bearing in mind that we have patients here that are connected and also patients online, how long do you think a clinical trial should last to see whether there is a response that has an impact on the patient's functionality? Because maybe we're ruling out drugs that if we waited long enough, there might be a response. What do you think about that?
Yeah, I think that's a good question about the response. So I would say at least 12 months to rule out whether there's a benefit. So I think there are a couple of examples now. Also, if you look at Riluzole, it took also about 9 months before we see separation in like the survival experience of patients. And we have seen it in the past as well. And like with tofersen, of course, like the example that you gave. So doing it. If you really want to think about like clinical benefit and prove that, then probably at least a 12-month study is required. The longer, the easier it becomes to show that, and the less patients you need to do. So there's a trade-off there. But for the biological efficacy, there's also a role. So that can show much earlier. I'm not so sure if we should only go for neurofilaments, but we had the discussion already.
It depends on the mechanism of action of the drug, the proposed mechanism of action. We shouldn't forget that there are also potentials for drugs that may not change the biological process of the disease, but still are beneficial. New Dexter, for example, quinidine and dextromethorphan. And I had on my slide, Parkinson's disease is not a curable disease. We have no disease-modifying drugs for it, but we can make the symptoms better for a period of time. So we shouldn't forget that either. So it depends on what we think the drug is doing as to how long a trial should be. Yeah.
I wanted to ask also about Ruben, you talk in your presentation, you talk about a small benefit. And I want to ask two questions related with that. What is a small benefit for you? And how should we power the clinical trials for? Because they are usually empowered to detect 25% of difference in the progression rate. Is that right? Is that a lot? Is that few? Should we? What should we do? Because 25% is more or less the effect that has Riluzole according to trials. This 25% prolonging survival and lowering the progression rate, and it's something that patients and as a clinician is difficult to detect in the clinic. You don't see this difference, but still, is this significant or not clinically or for the patients? Makes sense or not? Should we focus on larger effects, or should we try to?
No, so I think we should keep with the small effects, because this is how they solved in the end the HIV as well. By adding multiple drugs with smaller effects, you get like the synergistic larger effect. So I think that's the idea. We shouldn't be targeting only like the game changer drugs. I think that's the chance that you find it is very small. So regarding small effect, I'm thinking about like Riluzole. That's a small effect. It's relevant, but it's small. So I think we shouldn't go much smaller than Riluzole, but like try to go for Riluzole. And in survival time, it's a 25% reduction. But if you look at the ALS-FSR, it's actually much smaller. So it's probably only like a 5 to 8% slowing in the ALS-FSR progression rate that Riluzole does. So my worry with the 25% reduction that's commonly used in trials for ALS-FSR is actually that's too big, that's too ambitious. And we should be targeting probably a more realistic effect size would be like a 10% reduction in ALS-FSR. But if you do that, you need much larger trials. But I think that's the truth that we live in, that we have been conducting too short trials, too underpowered, too small. And that's also part of the reason why we've been missing so many treatment effects potentially.
Maybe we should just change the ALS-FRS and use something else.
Yeah. Which tells all of the difference between the two groups of ALS-FRR.
But there's two problems here. One is, what the drug is doing and whether it works. There's three problems. One is, can we see an effect? The second is, does the person who have the disease feel the effect? And the third thing is our scale any good? Yeah. And the third thing overrides the other two. And the third one is that the ALS-FRS is a big problem. I'm sorry.
I completely agree. I think it's not we have tried it now for 25 years, the ALS-FSR as a primary outcome, and none works. So I think that says something. So I would very much probably go back to the Riluzole area where we just showed like true drug effects on like extending the survival time. That's important.
If we had better data-driven markers like the technologies or some of the other, I'm a big fan of quantitative EEG, as you know. Yeah. So there are other data-driven markers that we could use. The remote monitoring or digital technologies. Yeah.
And then also the neurophysiology markers that is not used, but can be.
Quantitative EEG.
You can quantify the differentiation.
There's a question. Hay una pregunta ahí.
Hi. I would like to know if you think that working with family members from people that has a patient in their family with a genetic mutation causative could help to find biomarkers in pre-symptomatic stages, and from these biomarkers maybe shed light into early events in the disease, which might shed light also in new targets for new treatments.
Sure. I mean, there is a big initiative in the US that is called PreFalls, that is led with by Mike Benatar in my university, that is following presymptomatic individuals at risk, presymptomatic people that and they're doing a lot of tests, a lot of questionnaires about what they are eating, what is their lifestyle, in order to detect that markers that can divide better if the people can eventually develop or not the patients. And the ALS, for instance, Orla mentioned before the cryptic exon peptide, that is HDGFL2. It's difficult to say it in English. And it has been detected in a presymptomatic C9orf carrier just before rising the NFL levels and before pheroconverter to an ALS. So definitively focusing on the presymptomatic, it's the way to do. I don't know if you want to add something.
I think absolutely we should be looking at as many family members as we possibly can. And I think we should focus not only on the people who develop the disease, but to me what's much more interesting is the people who don't. Yeah. You know, in English there's a famous detective called Sherlock Holmes, and there's a story in Sherlock Holmes about the dog that didn't bark. So, the hound of basketball, And so the people who have the variant but don't develop the disease have a huge amount to teach us about what is happening that's protecting them from developing the disease. So I don't like this idea of, you know, pre-symptomatic and phenoconversion, because I think it's very binary. And I think this is a process, and understanding the process in all of its iteration in people that are willing to allow us to study them is really helpful, because then we can segregate people who develop, you know, a progressive form versus people who might arrest, versus people who get FTD versus people who don't get anything. And there's something really valuable biologically in trying to understand that. What are the factors that are protecting people who don't develop the disease?
And it's even harder maybe in C9orf carriers, where you don't know which phenotype will develop, or what is really a phenotype that is caused by that gene.
So if there are no more questions, I think we can close the meeting. Espero que hayáis...
I hope that you enjoyed the meeting, the meeting today, the afternoon, with the top international and national speakers that we've had, and of course Miguel Angel on this panel discussion. And I want to thank the Foundation, Luzón Foundation, and the Ramón Areces Foundation once again for giving us the opportunity to meet here and to be here one more year. And next year we'll meet again. Thank you very much.